of potentially reversing and/or avoiding atelectasis. Atelectasis is a condition that occurs when the small lung units collapse, which is a relatively common complication in tracheostomized and ventilator-dependent patients. Treatment of atelectasis can include supplemental oxygen, CPAP, or mechanical ventilation with PEEP. Thus, the Passy-Muir valve can provide a cost savings by potentially reducing a patient's oxygen requirements and possibly eliminating the need for mechanical PEEP or CPAP. The Passy-Muir valve is an ideal augmentative tool for weaning the ventilator-dependent patient because it provides physiological benefits such as reestablishing physiologic PEEP, improving cough, and increasing respiratory muscle strength. The psychological benefits gained due to increased patient confidence and motivation also contribute to faster weaning. Use of the valve to shorten the weaning time for a ventilator-dependent patient can significantly improve the transitioning time from the ICU to the subacute care setting. This can substantially decrease ventilator support costs, which average $3,000 per day. In the decannulation process, the valve can be used as a transition step between an open tracheostomy and a capped tracheostomy tube. The valve provides the patient with an opportunity to adjust to a more normal breathing pattern and gain confidence, while the physician can effectively assess for airway patency. A study by Light et al. Found that decannulation time was reduced by an average of 5 days when compared to a standard capping procedure. With hospital costs of $3,800 per day for a tracheostomized patient, use of the Passy-Muir valve in the decannulation process could provide a savings of over $20,000 per patient. The valve promotes infection control by eliminating the need for finger occlusion and by offering protection from airborne particulates entering the trachea. The valve redirects secretions through the upper airway, allowing the patient to orally expectorate, reducing the contamination risk to others in the patient's immediate environment. HCFA data indicates a $1,700 per day cost for treatment of a pneumonia. Utilizing the Passy-Muir valve is a very cost-effective therapy in the prevention of infection. The Passy-Muir valves have been found to improve the sense of smell by reestablishing airflow through the oral and nasal cavities during exhalation. This improved sense of smell may lead to an increase in the patient's sense of taste, appetite, and caloric intake, which could ultimately impact the patient's nutritional status and recovery process. The valve can be utilized with children as young as a week old if they meet the assessment criteria. Introducing the valve as soon as possible post-tracheotomy is vital to normal speech and language development, as the child is able to cry, laugh, coo, and babble, which are not only important precursors to speech development, but are critical factors in the parent-child bonding process. The use of the Passy-Muir valve with infants can potentially decrease the cost of rehabilitation services related to the treatment of speech-language delays, which can cost upwards of $80 to $125 per session. A tracheostomy can raise many quality-of-life issues for patients. Finger occlusion is a very conspicuous action and prevents patients from using their hands while speaking. Difficulty with communication, as well as secretion management and swallowing problems, can discourage patients from attempting to socialize or interact with others. When using the valve, patients can breathe, speak, and use their hands more normally without drawing attention to the tracheostomy. Restoration of normal speech, reduced suctioning requirements, and improved swallowing also facilitate more active participation in life activities. Patients can function without feeling disabled and conspicuous because of their tracheostomy. Increased communicative ability can enable patients to regain control over their environment and facilitate an improvement in self-esteem and well-being. All tracheostomized and ventilator-dependent adult patients should be considered candidates for valve use if they meet the assessment criteria. Indications for use can include, but are not limited to, sleep apnea patients who are tracheostomized, bilateral and unilateral vocal cord paralysis, tracheomalacia, mild tracheal and/or laryngeal stenosis, non-obstructive laryngeal tumors, neuromuscular disease, chronic obstructive pulmonary disease, brain injury, spinal cord injury, ventilator-dependent patients, and patients who emotionally or physically are unable to tolerate plugging. Prior to placing the Passy-Muir valve on a patient, a pre-placement assessment should be performed to determine patient candidacy, identify any contraindications, and address any problems that may temporarily prevent valve use. Patient assessment is most efficient when a team approach is taken. The team members should include, but are not limited to, the patient, family, physician, respiratory therapist, speech-language pathologist, and nurse. It is essential that education regarding the valve and its use be provided to all team members working with the patient. Optimally, the patient should be awake, responsive, and attempting to communicate. However, the valve can be beneficial with selected patients functioning at a Rancho Level 3. The valve should not be used while the patient is sleeping. The patient should be medically stable in regard to medications, mechanical ventilation, and adjunctive treatment. Many patients in the ICU are appropriate for the valve. It is vital that the valve be made available to these patients as soon as possible post-tracheotomy to enable them to direct their care, provide informed consent, and communicate with their loved ones. Cuff deflation is mandatory when utilizing the PMV in order to allow expired air to pass around the tracheostomy tube and through the oronasal pharynx. If it is determined that the patient cannot tolerate cuff deflation initially, for example, due to risk of gross aspiration or need for intensive critical control over mechanical ventilation, the patient should be reassessed for cuff deflation as changes in his or her medical condition occur. An alternate means of communication should be provided to the patient in the interim. Due to the restoration of a closed system, use of the valve can facilitate mobilization and oral expectoration of secretions and improve bronchial hygiene. Secretion viscosity is more critical than quantity when considering valve use. The ability to manage differences in viscosity and quantity of secretions will vary with each patient. Patients have reported their suctioning needs have decreased from every 20 minutes to 3 to 4 times a day with valve use. To determine airway patency, first check the patient's diagnosis to ensure there is no known airway obstruction, such as a tumor, stenosis, or granulation tissue. The tracheostomy tube should be sized to facilitate sufficient exhalation around the tracheostomy tube. The presence of a cuff on the tracheostomy tube may affect airway patency by creating an obstruction to airflow, even when completely deflated. Downsizing or changing to a cuffless tube may be necessary to allow for more airflow around the tube. The valve is contraindicated for use on a foam-filled cuffed tracheostomy tube. The valve may be placed 48 to 72 hours after the tracheotomy is performed if tracheal edema and/or secretions have decreased. Some patients may experience tracheal edema following a trach tube change. These patients should be assessed carefully to ensure airway patency. Careful assessment for valve use is needed to avoid potential complications associated with air trapping that can occur with non-elastic lungs, such as with severe COPD. An appropriately sized tracheostomy tube is crucial when considering valve use. It is necessary to evaluate airway patency prior to valve placement. If your patient has a cuffed tracheostomy tube, slowly deflate the cuff until all of the air has been removed. Instruct the patient to inhale through the tracheostomy tube. Manually finger occlude the tracheostomy tube with a gloved finger as you instruct the patient to exhale through the mouth and nose to ensure adequate exhalation. You should encourage the patient to vocalize by saying "ah" or counting to determine presence and quality of voicing. Although some patients may be able to exhale adequately, they may not be able to vocalize initially and may require voice assessment and/or retraining. Some patients may require repeated attempts of these steps to become accustomed to exhaling through the upper airway. Once it is determined that your patient is able to tolerate finger occlusion, you can proceed with placement of the valve. After the pre-assessment criteria have been met, the following steps and general guidelines should be considered in conjunction with the physician's order. Tracheostomized patients are often anxious. Therefore, patient education should be provided prior to valve placement to reduce anxiety. It is appropriate to involve the patient's family and care providers as they provide additional support and motivation. Educational activities include videotapes, diagrams, and demonstration. Bedside assessment should be performed before, during, and after valve placement, as determined by the patient's normal baseline and physician direction. Prior to placement of the valve, baseline measurements should be obtained on clinical parameters such as breath sounds that are decreased or have a prolonged expiratory phase may indicate airway obstruction, saturation, heart rate, respiratory rate, change in patient's color, work of breathing, and patient's responsiveness. The patient should be positioned comfortably, usually at a 45-degree angle or sitting position, to facilitate diaphragmatic movement and maintenance of a patent airway. The tracheostomy tube should be correctly aligned in the trachea to maintain a patent airway and patient comfort. Suction is needed prior to placement. Secretion accumulation in the oropharynx may require tracheal and oral suctioning before deflating the cuff. For infants and small children, especially obligate nose breathers, you may need to suction nasally. If the patient has an inflated cuff tube, suctioning during cuff deflation is desirable to catch secretions that have been sitting on top of the cuff, which may penetrate to the lower airway. Deflate the cuff slowly, allowing the patient to acclimate to the sensation of airflow through the upper airway. It is imperative that the cuff be completely deflated prior to placement to maximize the amount of space existing between the tube and the tracheal walls for adequate exhalation. Attach warning labels provided with the PMV to the pilot balloon of the patient's cuffed tracheostomy tube at the patient's bedside and/or in the patient's chart. The PMV 005, PMV 007, PMV 2000, and PMV 2001 fit directly onto the 15-millimeter hub of adult, pediatric, and neonatal tracheostomy tubes. When using the PMV 2000 clear or PMV 2001 purple speaking valves, place the Securate on the PMV before placing the valve on the tracheostomy tube. If using the PMV 2000 or PMV 2001 speaking valves, you can use the PMA 2000 oxygen adapter to deliver low-flow supplemental oxygen. Up to 6 liters per minute may be delivered in front of the diaphragm of the valve. To attach the valve, gently stabilize the tracheostomy tube with one hand while attaching the valve to the 15-millimeter hub with the other hand, using an approximate quarter twist. The valve has a friction fit for secure placement. The valve should never be forced onto the tracheostomy tube. The valve can be used with fenestrated or non-fenestrated tubes. However, even with fenestrated tubes, the cuff must be completely deflated. For patients using metal tracheostomy tubes, the PMV 2020 speaking valve and adapter may be used with the appropriate tubes as discussed earlier. Please see the PMV 2020 instruction booklet that comes packaged with each valve for further information. Some manufacturers of metal tubes offer an optional 15-millimeter hub for the inner cannula, which will allow for connection of the valve. The 15-millimeter hub inner cannula may be ordered from the manufacturer or distributor. Another option is a plastic endotracheal tube adapter sized to fit a low-profile metal tracheostomy tube to create a 15-millimeter hub. Humidity can be applied at the tracheostomy tube site with the valve in place via use of a trach collar or T-piece. The performance of a heat-moisture exchange filter may be reduced when used in conjunction with the valve, as exhaled air no longer passes through the filter, which traps moisture. The baseline measurements described earlier should be carefully monitored for significant changes while the patient is wearing the valve. If significant negative changes are observed, remove the valve immediately. If the patient experiences difficulty utilizing the valve, there may be airway obstruction, possibly due to stenosis, masses, secretions, or a tracheostomy tube that is oversized for the patient's trachea. With correction of the obstruction, the valve can once again be used. Some patients are able to wear the valve for 15 to 30 minutes or longer on the first attempt. Other patients need to start more slowly, gradually increasing the time that the valve is worn by a few minutes each day. If the patient appears to be tolerating the valve, they should be encouraged to exhale through the mouth. Have the patient attempt to vocalize an ah, count to 10, or repeat some simple phrases and sentences. Many patients will be able to speak well after the valve is placed. However, other patients will need to practice these simple activities to improve their speech and voice production. This may be due to vocal cord atrophy, damage, or neurological deficits. At the end of the initial therapy session, remove the valve and monitor the patient. When removing the valve from the tracheostomy tube, place one hand gently on the neck plate to keep the tracheostomy tube from moving, and with the other hand, gently twist the valve off the hub of the tube. If using a tracheostomy tube that has a hub that rotates, it may be necessary to use a rocking rather than a twisting motion to remove the valve. Reinflate the cuff if present. Continue to monitor your patient after the valve has been removed to ensure stability. Ideally, patients will gradually reach the point where they can tolerate the valve during all waking hours. It should be noted that due to a patient's fluctuating respiratory status, for example, presence of infection or thick secretions, his or her tolerance of the valve could vary from day to day and week to week. All tracheostomized ventilator-dependent patients should be considered candidates for the valve if they meet the assessment criteria. The Passy-Muir valves maintain their closed position no-leak function during mechanical ventilation, which provide the important secondary benefits as mentioned earlier. The valves can be utilized in most conventional modes of ventilation, including assist control, SIMV, pressure support, PEEP, and CPAP. The valves can be used in line with acute care ventilators, portable ventilators, and pediatric and neonatal ventilators. Placement of the Passy-Muir valve with a ventilator patient follows the same assessment criteria as the tracheostomized patient with some additional criteria. Obtain baseline parameters, as this provides the clinician with a starting point for ongoing assessment during valve trials. It is important to obtain your patient's history, especially information such as diagnosis, bronchoscopy reports, and arterial blood gas results when available. Of primary concern will be indicators suggesting reduced airway patency from repeated intubations, vocal cord paralysis, or other diagnoses. Educate the patient to the use of the Passy-Muir valve, letting them know beforehand what to expect when airflow is redirected past their vocal cords. This is especially important for the ventilator-dependent patient, as there is oftentimes a higher level of anxiety related to ventilator and tracheostomy tube issues. Position the patient comfortably for optimal airway patency. Obtain baseline parameters. This provides the clinician with a starting point for ongoing assessment during valve trials. These parameters include breath sounds, heart rate, respiratory rate, saturation, patient responsiveness, secretions, and anxiety levels. Record the patient's current ventilator settings and pressures, such as mode of ventilation, mechanical and spontaneous respiratory rate, mechanical and spontaneous tidal volume, FiO2, PEEP, alarm settings, and most importantly, peak inspiratory pressure and/or pressure support levels. The pressure measurement is a key tool in determining the need for potential volume and/or pressure changes during the cuff deflation process. Suction the patient's airway both tracheally and orally. Allow your patient time to recover from suctioning. Then slowly deflate the cuff, taking 1 to 2 minutes for complete deflation. This allows for gradual acclimation to airflow through the upper airway. This gradual flow stimulates the oropharyngeal muscles, facilitating improved function, which creates tone in the upper airway, and in turn creates resistance that will prevent large amounts of air from escaping through the mouth and nose during the inspiratory cycle. Exhaled air will either be directed up towards the upper airway or through the tracheostomy tube back to the ventilator. Therefore, we will no longer be able to accurately measure exhaled tidal volume. For this reason, we must rely on the pressure-volume relationship within the lungs to determine ventilation, much like we do with our neonatal and pediatric patients. If pressure drops, we know that volumes have also dropped. If the pressure remains the same, it is understood that the volume is being maintained. As you deflate the cuff, continue monitoring peak pressure. If the pressure should drop, increase tidal volume in small increments to maintain the previous level of pressure per physician direction. However, when a significant drop in pressure occurs, it is recommended that you re-inflate the cuff and begin a slower cuff weaning procedure. A large drop in pressure indicates that the oropharyngeal muscles lack sufficient tone to allow appropriate ventilation with the cuff deflated and will require further intervention. In this situation, after re-inflating the cuff, begin a slower cuff deflation process by taking approximately 1/2 cc of air out of the cuff every minute or so. This allows the patient adequate time to adjust physiologically and psychologically to cuff deflation. This gradual process gives the oropharyngeal muscles additional time to react to the sensation of airflow. This technique is especially appropriate for those patients who have been ventilator dependent with their cuff inflated for long periods of time. Once the cuff has been deflated utilizing this gradual method, if the valve is used on a regular basis, the patient will have acclimated and be able to tolerate normal cuff deflation. During cuff deflation, the patient may experience coughing due to mobilization of secretions. Allow the patient time to move and expectorate these secretions. When the patient has acclimated, assess airway patency. Encourage vocalization to determine if air is able to pass around the tracheostomy tube and through the upper airway. If the patient is having difficulty redirecting exhaled air, reassess for airway patency. Now that the cuff has been completely deflated and the patient is ready, the valve can be placed in line. All Passy-Muir speaking valves, with the exception of the PMV 2020, can be used in line during mechanical ventilation. The PMV 007 is designed to fit into disposable ventilator tubing and is most often the valve of choice for inline ventilator use. However, the PMV 005, PMV 2000, and PMV 2001 can also be used in line with non-disposable flexible rubber tubing. The valve does not need to be placed directly on the hub of the tracheostomy tube, but must remain as close to the tube as possible for optimal function. The valve can be placed with an inline suction catheter such as the Ballard or Portex. However, those catheters with a T-piece configuration and a 22 mm outer diameter on each side require the use of a 1522 step-down adapter, which is available through Ballard Medical. Due to the closed position no-leak design, the PMV does not increase dead space and may in fact reduce it. The valve can also be utilized with swivel adapters or an OmniFlex adapter for increased patient comfort. It can be used in conjunction with standard humidification devices, such as a Concha system, as humidity does not affect valve function. The valve can also be adapted for use with pediatric circuitry, utilizing a 1522 step-down adapter. As mentioned earlier, you may need to make some ventilator adjustments, which may include volume adjustments during cuff deflation and possible volume, pressure, and apnea alarm adjustments. Portable ventilators have pressure alarms, but do not have the volume and apnea alarms that are typically found on acute care ventilators. Therefore, the only adjustment necessary will be made to the pressure alarms. Acute care ventilators have a combination of volume, pressure, and apnea alarms. The volume and apnea alarms can be reset manually when the patient will only be using their valve for short periods of time. For longer periods of use, adjustments can be made to minimize unnecessary alarming. Some ventilators, such as the Puritan-Bennett 740 and Puritan-Bennett 760, have a speaking valve mode that will allow use of the valve without constant alarming while maintaining alarm functions. Other methods can be utilized to cease unnecessary alarming, such as adding flow or an IMV bag with flow to the expiratory limb of the ventilator circuit and setting the alarms appropriately to the volume created by this flow. Pressure alarms must be set as sensitively as possible to ensure an alarm trigger for disconnect, as well as a trigger for high pressure, which may indicate airway obstruction. The patient's airway pressures should remain within their normal allowable limits during valve use. Oftentimes, you may see a slight increase in oxygen saturation with valve use due to the benefit of physiologic PEEP. On the other hand, some patients may experience slight oxygen desaturations. In these cases, FiO2 can be adjusted to compensate. However, if the patient has significant desaturation, the valve must be removed and the patient reassessed. Due to anxiety or work of breathing issues, some patients may benefit in a change of ventilatory support. Some may respond better to an increase in rate or a change in mode, such as from pressure support to SIMV, or sensitivity adjustment that may allow easier triggering of the ventilator breath. Each of these should be assessed on an individual basis. Many adjustments can be avoided with use of slow cuff deflation techniques, as previously described. Once the valve is in place, the speech pathologist can begin facilitating verbal communication. The patient should be trained to vocalize on exhalation only to ensure proper ventilation. Go slow to avoid overtaxing your patient. Start with sounds or words and work up to sentences. Use of the valve should be limited during the initial trial so as to not fatigue the patient. Fatigued patients are less motivated to continue valve use. After the initial valve trial, length of use may increase significantly depending upon patient tolerance. When treatment has ended, the valve is removed and the original circuit setup is replaced. Return the ventilator settings and cuff to their original pre-valve status. Observe the patient for several minutes to ensure stability. Anxiety is a primary issue for ventilator patients. Patients who are mechanically ventilated for an extended period of time naturally become more anxious with any manipulation of their ventilator and tracheostomy tube. To reduce this anxiety, it is helpful to have the speech pathologist available to assist with transitioning. Educating the patient to the process of valve placement will decrease anxiety as well. Often, ventilator-dependent patients experience depression and may not want to participate in therapy or conversation. Solicitation of family involvement and psychological intervention may be necessary. Using the Passy-Muir valve during family, doctor, and therapy visits or telephone conversations may motivate the patient to participate more actively with their care. With this increased autonomy, depression may be improved. Airway patency plays a significant role in tolerating valve placement. If the patient is unable to exhale adequately through the upper airway, remove the valve and reassess the following. Make sure the cuff is completely deflated. Evaluate the size of the tracheostomy tube. If it is too large, suggest downsizing to increase airflow around the tube. If the tube has a cuff and it is no longer necessary, suggest changing to a cuffless tube. Position your patient to ensure optimal airway patency. If your patient is slouched or the ventilator tubing is pulling on the airway, it may cause airway obstruction. When the cuff is deflated, secretions in the upper airway may move towards the lower airway, causing obstruction of airflow. Therefore, the patient may require repeated suctioning. Reevaluate for airway obstruction. If each issue has been identified and corrected and the patient continues to exhibit distress, consult the physician regarding the necessity of a bronchoscopy to detect airway lesions such as tracheal stenosis, vocal cord paralysis, or granulation tissue growth. Some patients have difficulty getting used to the change in breathing patterns. Ventilator-dependent patients are no longer used to exhaling through their upper airway and may forget how to exhale through their mouth and nose, requiring the clinician to work on various exhalation techniques and abdominal breathing exercises. Some patients may experience a continuous rush of air through their upper airway. This rush of air may occur in volume modes and pressure support, as is evidenced by the inability of the patient to cycle off the flow. This is usually